My name's Luke O'Brien. I'm a physical therapist here, and I've been here for a little while now. And we had our hello goodbye party, what was it, 2 weeks ago, 3 weeks ago now? And it was an absolute point where I sat there and I realized how long I have been here. I looked down around the room and I thought, geez, I'm not sure that, apart from some of the SAC committee and Dr. Steadman and Dr. Rodkey, that I'm not sure that anyone that was here when I was first coming to these and swinging from the rafters, that any one of those people is still here. And so it was an absolute point of reflection for me, because I thought, what's happened in this time that I've sat here for 15 years and I've seen all these people come and most of them leave, and what have I done and what have I learnt? And so, unlike almost every one of you, I had no idea what the Steadman Hawkins Clinic was at the time. I didn't know anything about Vail, and I was on an adventure. So I'm from Brisbane in Australia, East Coast, about 1,000 kilometres north of Sydney, for those of you who have not been there. And I didn't have a plan. So I left Brisbane, hopped on a plane with one of my buddies, and we just happened to land in Denver. We didn't know anyone, we didn't have a place to stay, and didn't have a job. And to top it all off, it was December, and I had a grand total of $800. So what happened was the Greyhound bus, the first Greyhound bus out of Denver Airport, was to Vail. So I hopped on the Greyhound bus, and I stayed in the Roost Lodge, which has now been demolished in West Vail. It's just it was so bad, they just scraped it, but they didn't build anything over it. And what I found completely changed my life. And I can't possibly put all of the people that had an influence on me over the last 15 years. But I have to start with Dr. Steadman, because for 15 years, every other day, I'd see him. And we'd have a conversation about patients. We'd talk about Johnny Manziel running around at Texas A&M. We'd talk about the Broncos. We drove to the Broncos once, and he told me, he's got a brilliant manner about him where he'd sit in the car and there's this silence. And then all of a sudden he'd just pipe up and said, I treated Elvis once. And he was serious. He treated him in Lake Tahoe. But Dr. Steadman had a profound influence on me. And one of the things that he enabled me to understand was he taught me a way of thinking about the knee that was completely different to any way that I had thought about a knee in the past. And that the knee doesn't function in isolation. It is an entire system, and the effect of an injury at some part of the joint will influence the way that the joint functions in some other part of the joint. And then Dr. Fagan, who taught me that orthopedic rehabilitation, successful orthopedic rehabilitation, is about a team. And you cannot function in isolation, and that you have to have an entire team around you working in harmony to get the best outcome possible. I put Dr. Hawkins on here because Dr. Hawkins taught me, and I'm not going to tell a story, but he absolutely taught me that orthopedics can be fun. And there was a lot of laughter and joking going on in Dr. Hawkins' clinic, but they still got the job done. And Dr. Prad, who took my kind of environment of understanding of the knee with Dr. Steadman and put an anatomical foundation on top of that. And then lastly, are the patients that I've seen while I've been here. And obviously I've seen more than 3. But these guys were 3 that I've chosen because they taught me a lot about one of the things that I'm going to speak about today, and that is the importance of load and load monitoring in rehabilitation. So this guy here is Owen Hargreaves, midfielder at Manchester United. Before that, Bayern Munich, won 2 Champions League titles. Pretty high level player. And he was really the first one that got into my mind about, if I don't get this right, the consequences, regardless of how good the surgery are, regardless of how well I design strength programs, is completely futile. The second guy here, I'm sure few of you know this guy, Greg Oden, #1 draft pick. Didn't have a very good time of it in Portland. And I would say, that if we didn't institute the load monitoring stuff that we learnt from Owen Hargreaves, that Greg would never have gotten back on a court again. And then lastly, Grady Sizemore, baseball player, Cleveland Indians. I think he's still running around now at Tampa Bay. And the same situation that was Grady was from Greg, is that we learned that we have to have a loaded and progressive training program, and that if we don't, it doesn't matter how good our condyle resurfacing techniques are, because they ultimately fail if we load them too quickly. So today, I've sat through some boring rehab talks, some of them in this room, and I'm not trying to give you the nitty-gritty, all the details that go on and what I would do with a patient, but I want to give you some of the highlights, some of the points that I think are important when you're considering what rehab can do for your patients, but also the decisions that you make in releasing your patients to let them go back to play. And hopefully we'll keep it a little interesting. So I try to break this up into 4 areas. They're not all specifically related, but the 4 areas are motion, and that range of motion is the foundation of the acute knee. Without motion, it does not matter what you do. It doesn't matter how good you did your surgery. It doesn't matter how strong these people get. They're not going to have a great result. The second one is planning. In my opinion, and something that it took me a long time to learn, every patient needs a plan. When they have an ACL surgery, they have a multi-ligament surgery, a meniscus surgery, when they sit on the table day 1 after surgery, they don't know how they're going to get from that table to returning to sport or returning to whatever activity they're going to do. And so they need an outline or a plan to help them get there. The next one is monitoring. And I've written here that inappropriate application of load to a patient can be catastrophic to outcomes. And it sounds probably a little bit strong, but my point in saying it is if you get it wrong, results are bad. And it's an important thing that we don't always consider that we need to be considering. And then lastly, I'm going to talk about measuring. And that sensor technology is revolutionizing our ability to collect lab quality data and apply it in clinical settings. And so I'll talk a little bit about that later on. So, motion. No matter what the surgery that you have, the goal is always the same. So if it's one of Dr. LaPrade's multi-ligament knee injuries, if it's Dr. Singleton doing a knee scope, if it's Dr. Hackett doing an ACL, it doesn't matter other than we're protecting the surgical repair. We want to restore symmetrical flexion extension, patella mobility, no joint effusion, no joint heat. At this point, nothing else matters. For a lot of people, this may be a different approach from the places that you have come from. And there is a kind of a pervasive notion or idea in sports medicine that you need to get strong first. And from the thousands of knees that I have seen over the last 15 years, from my opinion, the last thing that you need to do in a joint is to make it strong first. You first have to create the environment that you are able to have an effective strength program. Without that, your strength program is completely useless. So creating the right environment, creating joint homeostasis first is what sets you up for success. So why is it important? Well, you'll never ever see a patient that comes in with an unstable knee that you then make stable, but they've lost 40 degrees of knee flexion, who are happy with their joint. So it's essential to patient satisfaction that you have great mobility. The next is joint preservation. 10-degree flexion contractures are catastrophic to the chondral surface. If these people try and run around and play soccer and ski, and they are guaranteed in a short period of time that they're going to start delaminating and having femoral condyle or trochlear groove issues. And so it's essential for joint preservation that we restore motion. And then lastly, strength development. It is impossible to restore a normal quadricep function with a knee that has even a 5 or 3 degree flexion contracture. And you all know this inherently. You can make a great bicep with an elbow that is bent, but try and do it with an elbow that is straight, and your force production capacity is down here somewhere. And so the same thing happens at the knee. You have to have an extended joint to be able to have a normally functioning quad. So it's not that important that we understand, that you understand all the ways that we get it, but it is right down the bottom here important that frequently there is this perception that you turn up to physical therapy and you need to take painkillers and you put a piece of dowel in between your teeth and it's time to bend. And that is absolutely the wrong notion of what we do, because we are not good enough or strong enough to overcome the muscular force of anyone's leg. So if we're creating such a large pain experience for a person that they're having all this muscular guarding, it's completely useless what we're doing. So it has to be, my words, discomfort is good, pain is not. You should be aware that you had surgery, you should be aware that we're bending a joint into that end of range, but it should not be a painful experience. And it's very important, I think, that we do that for success. So I'll channel my inner Dr. Steadman here when I say that patella mobility is the key to the knee. I can't tell you how many times he told patients this, but it's definitely more than 1,000. And the reason is that you never ever see a good knee and an immobile patella. They don't exist. And so for everyone, so we're all working from the same level of understanding, the reason that the patella is important is because you need these anterior interval and suprapatellar pouch spaces to gain the motion that we just said was essential to a joint. Without those spaces, without the femur and the tibia moving into them, the patient's knee is stiff and they're usually always unhappy with it, and the contact pressures build up within the joint and cause issues. So we have a pretty heavy emphasis on mobilizing the patella, medial lateral, superior inferior, to maintain, or an attempt to maintain the integrity of those interval spaces. And one of the other tools that we have is the quad set. The quad set is this overlooked exercise that is in PT that we should place much stronger emphasis on making sure that not only is it done correctly, but it's done multiple times. And the reason for that is, one, when it's done correctly, it always maintains joint extension. But it also, when done correctly, opens up the interval spaces and locks them back down again. Because when you go from an extended knee sitting at 0 to an fully extended knee at -5, your anterior interval spaces open up to allow that extension. And when you relax, it goes back down again. It just keeps on opening and closing, and doesn't allow that tendon to tack down. All right, so at Dr. LaPrade's VIX course, must have been 2 months ago now, these are the slides that I hate to put up, but when you put them up, about 100 phones start to come up out of the crowd to take photos. And for me, this is actually one of the least important slides in here. But for the orthopedic surgeon community, this is what people want to know. When are you restricting? What are you allowing to do? It's almost hard to believe, but probably even as recently as 5 or 7 years ago, my guess is that we were doing about 80%, maybe more, ACL allografts. And I bet now that that number is maybe 5%. Dr. LaPrade, would you? So this is probably a remnant, but this was how we would treat ACL allografts at that point in time. Our parameters here for bone, tendon, bone, and a hamstring, you can see I don't think that we're either the most aggressive or the most conservative, but we have a period of time here where we protect them, we brace them while they have a femoral nerve block in. But one of the things that I do think is important here is this period of partial weight bearing. After the nerve block wears off, patients can walk. They're not on crutches because they can't walk. They're on crutches because they've had an acute injury, and walking on it with the muscular dysfunction that they have a couple of days out of surgery doesn't usually help us restore motion and get the joint back to homeostasis as quick as we can. So microfracture and meniscus stuff. Really the only things that I want to point out here is the differences between a trochlear groove and a femoral condyle. So you can see in here we're touch-toe weight bearing with a femoral condyle for 6 to 8 weeks, but with a trochlear groove we do it for 2 weeks. Obviously the reason being, if you walk around with a knee that is flexing and extending, the patella moves into the trochlea, and it has a compressive effect over that microfracture area, and it shears off the blood clot, and it doesn't get the results that we were after. The other thing is that there's a really long time frame before we would begin muscular strength, and this is something that I believe that I contributed to. And the reason is that microfracture cartilage responds poorly to rapid increases in load. So if you have not walked on your leg for 8 weeks, and then at 9 weeks, all of a sudden you decide, I'm going to walk, I'm going to go back to work, and I'm going to start a strength program, these knees almost always respond poorly. So from a period of 8 to 12 weeks, what I would like to do is this little phase called weight-bearing tolerance. If you could increase your walking time through about 30 minutes, then usually then you're able to begin a strength program that doesn't negatively affect the joint. And lastly, we'll call it our scope or the package. So we have a period of time here where we would have a standard kind of application, where they're partial weight bearing for 1 to 2 weeks. They begin spinning on a bike day one. They have a kind of a pushed out strength program that kind of allows that joint to settle down before we load it heavily. And then we have an accelerated one, which really you have to have a relatively special situation, mainly being you're a professional athlete, gets paid a lot of money to return to sport as soon as you possibly can. And in that situation, we absolutely would alter our plan. So, that's my 30,000 foot view of our acute knee. What I want to move on to next is planning. And I realized this last year when I had a minor procedure done that I didn't know anything about. And you walk into the doctor's office, he said, okay, well, we're going to do this, we're going to stick a scope in, and then you're just going to magically be better. And I realized that that wasn't the case. I didn't understand what was going on, but I also didn't understand what's the point from when I start this process, how do I get back to where I need to go? And it really drove home for me the importance, particularly in physical therapy, when we sit down with a patient on a table day one, they've had an enormous surgery, they're frightened about their ability to return to the previous activity level, and we just start talking to them about, okay, we're going to bend your knee and straighten your knee, it might hurt a little bit, but we don't necessarily do a great job of saying, at week 1, we're going to do this, and at week 4, we're going to do this, and at week 16, you're going to be doing single leg squats, and at week 24, you're going to start running progression, at week 30, you're going to do speed and agility, and here is your roadmap of how you're going to get from day 1 to day 130, where you're going to be returning to sport. And so, one of the ways, the way that I grasped onto to understand how I could create great plans for patients was to understand the concept of periodization and the way or the role that it could play in helping me develop great plans. So I don't think there's actually a whole lot of point in this one. So let me go into here. So there is very little information in the rehab literature regarding the optimal design of resistance training programs for injured athletes. It may sound very surprising, but if you look at, there is numerous amounts of literature looking at optimal loading parameters, so set and rep structure, rest times, what percentage of 1 RM you should be doing in a normal patient population to redevelop or restore muscular strength. But as soon as you transition over into rehab literature, you look at any of the ACL stuff, there is almost nothing. And to compound upon that, when you look at popularized protocols, there is almost no comment ever about how or the parameters by which you perform the exercises listed in these protocols. So you could look at, let's look at Dr. Andrews and Kevin Wilkes' work. They will say, do a quad set, do a straight leg raise. But there's never any comment about how you do it. It's almost like me saying, you drill a tunnel in the tibia, but you never make a comment about the angle of entry, how you make an incision to get there. So not only does periodization, periodization is effective in improving strength in strength and conditioning literature, but there are many different ways of having periodization programs. The one that I have grasped onto is linear periodization, and it basically involves taking a physiological component that you want to develop. So let's say it's muscular endurance, and you focus on that component for a period of 6 weeks, and all of your training parameters are designed around developing that to its potential, and then you move on. So you develop muscular endurance, you then focus on muscular strength, you then work on muscular power, and then you move on to your speed and agility work. The reason that I think it's beneficial is not only does it allow those components to be fully developed, but it immediately crystallizes a plan of what you're going to be doing after surgery. So here is a sample. So I know that after surgery that I'm going to be focusing 0 to 6 weeks on range of motion protecting surgical repair. And if I have a multi-ligament knee and they're going to have a period of non-weight bearing or limited weight bearing, I'm probably going to need a couple of weeks where I begin to focus on increasing their weight bearing tolerance. And then in here you see kind of the classic linear periodization. We're going to focus on muscular endurance for 6 weeks. We're going to have training parameters surrounding muscular endurance, so about 60 seconds of rest time in between sets, a high rep structure with a lower load. And then we're going to move on strength, power, running progression, speed and agility, return to training, return to play. And so immediately you can sit down there with a patient and say, here is your outline. Here's your roadmap of how you're going to get to sitting on a table with a femoral nerve block in and all these bandages to returning to the field and doing what you want to do for the reason that you did this surgery in the first place. So for most patients, I would use a linear periodization plan. In fact, I'd say 90-something% of patients. But in the small cohort where you need to return them to activity quicker than what we may always do feel comfortable doing, you would use a non-linear plan. And a non-linear plan simply is when you train a different component every day. So on Monday you would choose muscular endurance, on Wednesday you choose muscular strength, and on Friday you would choose muscular power. And that has been shown to have very equivalent results in terms of developing those strength characteristics as a linear periodization. But obviously we don't necessarily need to have that aggressive input for patients that aren't getting paid hundreds of thousands of dollars to play on the weekend. So when you're considering a plan, it's not quite as simple as saying, what are my periodization components and here are all the things that I'm going to map it out. You also have to ask yourself a few other questions. So one of the big ones for me, when is the performance goal and is it realistic? Patients have fantastic views or optimism about their ability to recover. And so you will have teenage girls that come in and say, my soccer season starts in 3 months and I'm going to be ready to play. And I think it's our responsibility to be optimistic about their outcome, but also realistic about their outcome. It's not realistic for that specific patient to have that goal of playing 12 weeks after an ACL. And so sitting there and saying, I believe you're going to play soccer again, 3 months might not be the timeline that we're going to aim for, let's have a more realistic goal, is very important. Set the expectation first. The next one is, when should you begin running and how much and what sort of running do they require for their sport? Running is this great benchmark in rehabilitation. And you see all manner of patients that probably have no business running early in their programs. So I think the classic one for me was Dr. Shelbourne in here saying, I'm going to mandatorily make patients lie in bed for, was it 3 days after surgery? But then after that, they basically can do whatever they like. So you've got 8 weeks out of surgery, and here are these patients that have a fixed flexion contracture, but they're running on their joint. And my point in that is the least important thing in a rehab program is the time that a patient runs. The most important thing is that you get them to a point that they can run without any issues and without any problems. The second part is not every patient needs to run. And even with the patients that need to run, it's a very different type of running that they will need to do. So if you're a baseball player, no offense to baseball players, you don't need to run for 20 minutes. If you were working through a running progression that I would use, I'd get you to maybe 3 minutes of running and 2 minutes of walking in a cycle, and that'd be it. But if you play soccer, it's a completely different demand. And so you need to run for more than 20 minutes, so that the demand is a lot higher and that we need to go further. How much training time do they require before returning to play? If you're a soccer player, usually it's going to take anywhere from 4 to 6 weeks of full contact training before you're going to be performing at a level that you're going to feel comfortable with before returning to sport. So when you're setting your performance goal, it's not quite as simple as saying, I know that the ACL graft is going to be incorporated and healed between 4 and 6 months, and you're going to be able to return at that time. You need to make sure that the athlete is not only healed, but is also performing at a level that's competent for them to return. And lastly, how much time do you need to regain range of motion? And how much time do you need to regain all the components of strength? And this is really part of the periodization plan that we spoke about earlier. So probably if I get on my soapbox and talk about something that I have absolutely no real empirical data about, but you go to physical therapy clinics around the country, particularly in ACL populations, and there is a hell of a lot of jumping going on. And in certain patient populations, in certain sports, jumping is absolutely important. If you're an NBA player, if you play volleyball, you've got to jump. But for the vast majority of people, you don't need to jump that much. Now, I know I did a sample of myself this weekend, and I haven't jumped yet. And so when you begin to consider what your daily demands are for patients and what the percentage of time spent in rehabilitation on certain activities is, you've got to marry these together so that they're aligned with the demands of what the patient needs. So I'm not saying that jumping is bad or poor or anything like that. I'm saying that jumping needs to be applied specifically to the needs, based on the needs of the patient. And lastly, highest risk of injury or setbacks. These high impact activities are the highest risk for re-injury or setback from overload injuries. So they are not risk-free, and that's one of the reasons why, at least in my practice, I need to have a justification of why I want a patient to jump before I'm going to make them jump. Okay, so we're going to move on from planning and we're going to move into load monitoring. And for about 2 years, I think now, I've presented on load monitoring. And it was a concept the first year, and I think that we're kind of at a tipping point, or at least I hope that we're at a tipping point now. I had the pleasure of spending a week at the New York Knicks 2 years ago, and we were in their training room, and they had this skeleton, sits there, it's a full-size skeleton. It's shorter than everyone that works there, but they have this sign on the skeleton that says, "You break them, we fix them." And there's not very many players on an NBA team, and there's a lot of staff. So I sat there for a lot of time, and I began thinking about this skeleton, stupidly. And I thought, why is it that it is appropriate, or that we have this notion that is appropriate to injure patients or injure players? And so I think that we need to challenge the assumption that injuring athletes is acceptable, because the consequence for performance is catastrophic. Now, this is you're not going to be able to see this, so I'll try and point it out, but this is the Dallas Cowboys preseason or current injury report. And I'm going to come back to it, but you can see the list on here of players that are either out or questionable based on, 2 weeks now of training camp, or the injuries that they sustained in the first 2 weeks. So why is this catastrophic for performance? Well, we know that injuries come in packages, with subsequent injuries accounting for around 40% of all injuries. And if we're going to play a role in preventing injuries, we 100% have to consider what load monitoring or the contribution that inappropriate load plays to the development of injury. So here is a really bad graph that I tried to make on the computer. These numbers on the side, they don't mean anything. I just can't get them to go away. So you have to look at 200 up here. But what 200 should say really is injury, right? This is the threshold at which injury occurs. So to understand injury, I think this is the way that I conceptualize it. You have a component of training load that contributes to injury. You have a component of environment, right? If you're a pitcher and you step off the mound and your foot slips and bang, you hyperextend your knee, that was the environment that caused that injury. And lastly, it's biomechanics. And when you have an uninjured athlete, you have all these three components functioning together that are underneath this injury threshold. But when you get an injured athlete, typically Not always. Typically, it's that training load has increased. Now think about the professional sports in the United States. When you go to training camp, you've turned up and you've sat on your butt and enjoyed summer, and then you turn up and all of a sudden your running volume or your pitching volume or your hitting volume has gone from, let's make it up, let's say you're doing 100 throws and now you're doing 100 throws in the morning. And your loading volume has increased significantly and you get hurt. And then you turn up into the rehab department and what do they look at? They start to look at, look at your scapula and it's winging a little bit, or you're weak in external rotation. Now I am not underplaying the role that biomechanics plays, because it absolutely has a role. But in that situation that I said, 100% the reason that person was hurt is because their loading volume went from here to here. And if you don't have a role in controlling loading volume, you're going to have no impact on their ability to get better. So there is a huge amount, I wouldn't say huge, a growing amount of literature that is beginning to support this. The best one that I think that illustrates it is this, and this is published now a few years ago, but it's a 25-year study that looked at decreasing the lower leg stress fractures in the Israeli army. So all these new recruits, they turn up, they make them march a lot, and then all of a sudden they started having stress fractures. Well, for 25 years, they began to say, you can't have all these people getting stress fractures, and what are we going to do about it? And so they looked at manipulating almost everything. So they changed their shoes, they changed their diet, they looked at what strength and conditioning programs they could do, and they came up with, if you had 6 hours of sleep and you didn't march as much, you decreased your injury rate from 30% to 11%. So irrespective of what we did as an intervention, don't march as much and recover from what you did, and your injury rate decreases 20%. So there's a lot of load monitoring that goes on in cricket. Now I know that I'm the only one in the room likely that knows anything about cricket. So I've got, this is a fast bowler, and I do this to show you really what the motion and what these guys go through. This is England, and this fast bowler doesn't really like the English cricket team. So you can see he doesn't care for their life and just bounces them and causes grief. But they go through, they run in, they have this delivery where they go from kind of a hyperextended position to a hyperflex position, and they develop stress fractures, particularly in younger fast bowlers. They develop stress fractures pretty frequently. So John Orchard this year published a paper that retrospectively went back and looked at the workload patterns of 235 individual fast bowlers. And what he found was if you bowled more than 50 overs, which would be, let me put it in baseball terms, basically 300 pitches in a 5-day period, you had a significant increase in the injury risk the following month versus bowlers who bowled less. It didn't matter about age, it didn't matter about the speed that they bowled, it didn't matter about the type of delivery they were doing. It was just totally, if you did this much volume, your risk significantly increased. And the same thing he looked at over a 17-day period. If you exceeded 100 overs, which would be 600 deliveries in 17 days, there was a significant increase in injury risk. So Hulen, which really builds upon the last study, showed that it is not the cumulative workload, but really it is the workload over the baseline. So I'll put this in running terms. If you were used to running for 4 miles and all of a sudden you ran 12 miles, then in this fast bowling study, you had about a 20% increase in injury risk. When your threshold was 200% above what the underlying volume that you were used to, there was a 20% increase in injury risk. So what we can take from this is that it's the spikes in volume that are problematic. So it's all well and good for me to say, okay, load monitoring is important. But if you don't have the tools to be actually able to monitor the load, then it's completely irrelevant. I think that, however, there is a lot of technology that is going to change our ability to understand and collect this data. And so, the US is beginning to catch up to the rest of the world in the use of GPS for monitoring athletes, not only during training, but also during play. So this is an Australian rugby player, and you can see top of his jersey here, this is a sewn-in GPS unit. And that GPS unit will be able to tell them a lot of things, but one of them being, it'll be able to tell you the distance that the player ran, or total distance covered during a game. It's going to be able to tell you the number of acceleration and deceleration events that the player had, number of contacts, and then the average speed that he covered. Now, why is all that important? Well, it's important from our perspective because I know that if I get a soccer player from Newcastle United and I need to return them to play, that I can pull upon their GPS data to say they're going to be running for an average of 37 minutes and they're going to cover this distance and they're going to run at this speed. And I can begin to tailor a rehab program that meets those demands rather than just guessing they need to run. I'm going to guess that they're going to run about 20 minutes and keep our fingers crossed that that's going to be sufficient. So you say, all right, that's well and good. You're a professional athlete and you get a GPS unit sewn in your jersey. That's not really applicable to a general patient population. But for everyone in this room who's got an iPhone, you have a GPS unit. And so this is an app made by Rosignol that is essentially exactly what I just said that you can download for free, and when you go skiing this year, you can start using GPS to track your own performance. So you can see it'll track runs, it'll track how fast you're going to go, average speed, distance, duration. And it's interesting to use this with patients because obviously if you've got 15-year-old Ski Club Vail kids, they want to see how high is my max speed, which may not necessarily be what you are looking to track, but it's obviously become a competition. But what it helps you do is to begin to understand duration. How long are these kids skiing for? How many runs do they do in a normal day? And from there, again, gives you real-time data to be able to say, this is where my training programs need to be. So with the research that and it wasn't exhaustive, but with the 2 papers or 3 papers that I presented, should we be advocating for athletes not to train hard? And that is absolutely not the message. Moderate training loads are actively protective against injury. That's intuitive and we all know this already. The real issue is when you have spikes and troughs. And the best example that I can give you in this is tendinopathies. So anyone that's ever worked with particularly a jumping sport team will know that you get to the end of the season, and this is classic in soccer and Australian rules football as well, and you get to the end of the season, you have a patient that has a roaring patella tendinopathy and you say, it's the end of the season, go home and rest, and you'll come back next year and it'll be good. And for anyone with experience with it, that's not what happens. They go home and rest, and they begin pre-season, and within about 3 days, they walk into the rehab room and they say, oh my goodness, my patella tendon is killing me. And the reason is because they were a loading volume here, they took time off, and they were here, and then all of a sudden, they went from running for about, let's make it up, 10, 20 minutes, and they're in training camp, and now they're running for an hour and 20 minutes. And their tendon had not accommodated, they hadn't given their tendon a time to accommodate to that load, and so they're presenting again with big issues. So my real message here is that troughs precede spikes, and spikes precede injuries. And our role should be in monitoring players and monitoring patients' loading volume is that we want to flatten out this graph, that it should look kind of just a steady up and to the right line, not something that looks like peaks and valleys. So, if we're able to collect the data, then what are we able to do with it? How are we going to be able to put it in some kind of system that we're going to be able to understand? So for the last 3 years, we've begun working with a software company. And if you were to go to almost any elite sport situation now, they all have athlete monitoring platforms. And that allows them to track a whole number of variables with their athletes. And so we are looking to do a very similar thing with our patient base, but try and shape and mold it to be more specific for a medical environment rather than an elite sport environment. It's taken us 3 years to get there, and this obviously definition is not going to show up very well. But this is the homepage that we have now worked on to create for individual patients. So it's an online platform. They get loaded up into here, and we can now track a whole number of different variables within patients. So for instance, on the homepage, I can set a program, and in here, I can begin to track what are my loading parameters, right? So on Monday here, I've got a high day. Here, I begin to have a lower load day. Here's a recovery day, and then I'll load them again. If I was to graph this over time, I'd want to look at making sure that my loading parameters are gradual and up and towards the right, and not my peak and trough stuff. I can also begin to track different wellness parameters. So when I have a high load day, what's it doing to the quality of sleep that a patient is getting? And what's it doing to the total duration that a patient is getting? And up here, when I look at, for anyone that looks at heart rate variability, we're able to begin to look at heart rate variability over time. Now these wellness questionnaires, a simple phone app. So there's an app sits on their phone. They hop up when they go and spin on the stationary bike after Dr. Philippon surgery. They got 20 minutes for them to fill out a 2-minute questionnaire about how well they sleep last night, what's their motivation. We are going to change some of these parameters because they're not the most specific, but it gives us an ability to begin to look at what are the effects of what we are doing on parameters that we may not always consider, but may be important in their recovery. And the last one is that it enables us to take outcome questionnaires and graph them over time. So if you're in New York, we can, through the app, begin to push outcome questionnaires and say, not only where are you, but where are you relative to your peer cohort. So if you had a hip scope with a microfracture, we know that once the database has sufficient numbers, that you should be in here. And if all of a sudden you're all the way down here, it triggers us or flags us to contact a patient to say, why are you not doing as well as we would expect? Rather than waiting for a patient to physically turn back up here when they may have been going not so well for 6 weeks and not be as honored as perhaps we could be. So it gives us, this platform, it is not perfect. I have absolutely pushback from our staff about implementing it, but it gives us the ability to begin to look at not only training load and the effect that it has on patients, but other parameters that may be important in their outcomes. So that's all on load monitoring. What I want to show you now is measuring, because I talked about the role that load plays, and now I want to talk a little bit about the role that biomechanics plays. So I have a video. Here's a patient of ours. There's a patient of Dr. LaTrobe's, and let me preface it. So, elite NBA player, and probably one of the most athletic players in the NBA. And if you were just to go off the way that he looked when he sat on the table and the way that he performs, you would think, well, this guy's not going to have any issues. But what I want you to have a look at in particular is have a look at the valgus that occurs on his right leg. Single leg drop, that's about an 8-inch box. Okay, so he struggles to stick his landing, which isn't the most important. All right, now have a look at him in double leg position. Doesn't land evenly, foot strike doesn't occur at the same time. Wide base support, which isn't necessarily bad. Now on this next rep, have a look at the valgus that occurs on contact, right knee. Now, my point in this is twofold. One, very frequently when someone like this would turn up to your offices, you would sit in there and say, motion's great, my ACL ligament is healed perfectly because he's 6 months out, muscle looks strong, you're clear to go and play. And there is a component of movement quality that we may not always do the best job of assessing to put the biological healing and the movement quality over each other and determining whether they're good to go. The second part is, we had Tim Hewitt here 6 months ago, and one of the papers that Tim has published, maybe one of the best ones, is showing that if you have an 8-degree increase side to side on dynamic valgus, that is an absolute ACL injury risk. Now for my eyes, I can look at that and I can tell you that's dynamic valgus, but I cannot quantify it. And there is no means short of having this patient turn up into the motion analysis lab and probably spending a couple of hours putting the dots on him and then another day crunching the data to absolutely quantify, does he have 8 degrees or not? However, what's occurring in technology is completely revolutionizing our ability to begin to collect this data. So everyone knows about an Apple Watch, and this is what is popularizing our understanding of what sensors are to capture a whole bunch of data. So from heart rates to body temperatures to blood sugar levels, now I'm not sure how accurate it is, but it also has the ability to capture movement. So within the last week, we've started using this product called Dorsavie. It is a movement capture system validated against Vicon, and it is a quick setup and it offers immediate data interpretation. So all it is one of these guys that has, I'm going to butcher this, but it's got an accelerometer, a gyroscope, and a magnometer. Now I can't tell you what the magnometer does, but in knee and running applications, all that is involved is for this sensor to go mid-tibia. So there's an adhesive patch that you can put on. And then it allows you to put patients through training parameters. So for instance, if I was to go and do, so if I'm going to do the knee, I can do double leg squat, I can do single leg squat, I can look at the 8-inch box where I land on one leg like we just described, and it begins to show us real-time data about how you're performing that movement. So here's my data, and you're not going to be able to see this because I can't really either, but it plots it out in what's your varus and valgus component. So this was a double leg squat for me, and I had, I can't even read on there, but I had about I think this is 3 or 4 degrees here on my left, and I think this is 6 or 7 degrees of valgus on my right. And if I come over here onto a single leg squat on my right leg, I have 7 degrees of valgus. Now, not only does it begin to tell you what your total valgus or varus bias is, but it also tells you that the speed, so in degrees per second, do you have 7 degrees of valgus, but it's occurring at 4 degrees per second, kind of insinuating that you have a control or ability to control that valgus? Or is it occurring at 37 degrees per second, which is probably more similar to the video that we just saw before, where it's basically this uncontrolled thrust into valgus? So it's not limited just to knee. So we can begin now to put these sensors on patients looking at running. So let's think now of an ACL patient that's beginning their running progression. And you can now look at average ground reaction force left to right. You can look at average ground contact time and then compare them right to left. So for me, I was here 3%, which in my opinion, 3% is not significant. You wouldn't ever do anything about it. But if you've got an ACL patient that's now presenting, that's got an asymmetry of 15, 20, 25% right or left, then that is absolutely something that's significant that you wouldn't want to let someone go out and perform at their athletic potential. So you can do it in the environment, but you can also take this RFD and put it in your pocket and then send them out onto a training field, and it'll capture 2 hours worth of data so that you can begin to get a sense of, all right, on 1 minute on a treadmill in a PT clinic, you look like this. But as you begin to fatigue over the point of 45 minutes into training or an hour into training, are those loading parameters still the same, or do they shift in a different direction? The other thing, and there was a nice article in JOSPT, I think 3 months ago now, that looked at force impact with jogging v force impact with running, and loading forces with jogging are higher than running. And it plays out on just the couple that we have begun to look at in here with running and jogging. And so perhaps it begins to change what we think about in terms of, do we begin people jogging, which because it was slower we thought was better, where it's really a higher loading and impact force on the joint, when really if we pick up the cadence, it may decrease those loading forces. So I guess my point in presenting that is that this will allow us for lab quality data that helps to marry the quality of our strength assessment on top of movement quality. So it's not just, are you strong enough? It's, are you strong enough with, do you move well enough? And if we marry those two together, I think we're going to be more effective and efficient in what we're able to do in returning patients to sport. So for all of this stuff, fancy GPS things, sensors, load monitoring, in my opinion, it sounds great. But ultimately, it's just a dashboard. And it's just like your car, you need to be able to interpret, if your oil temperature is getting too hot, if the petrol's getting low, the dashboard doesn't do anything for you. It's dependent upon you interpreting it. And so all this data is reliant upon the user to say, I know what 7 degrees of valgus is, and I know what I'm going to do to make it better. It's not the answer, it just helps us ask better questions. So that's it for me. I think the take-homes that I'd like everyone to leave here with is that motion is the foundation of the knee, and that if you don't create that base, that it does not matter what you do after. The second part is patients need plans, and using the concepts of periodization help patients understand a very long rehab process and keep them on task and on track of helping achieve their goals. Third is that load monitoring is absolutely important and essential in getting people to where they want to go. And if you get it wrong, it has really bad effects on their outcome. And then lastly, we should no longer be considering strength as the absolute assessment point for successful rehabilitation, but overlying it with movement quality and using sensor technology or other technologies to say, not only are you strong enough to return to sport, but you move well enough to return to sport. So that's it for me. If there are any questions, that'd be great. Otherwise, thank you. Dr. LaTrobe.
Thanks, Luke. So you're right, you made a lot of changes in the last 2 years. What do you need from us to continue to advance this?
Well, I think one is buy-in. I know that I don't get absolute buy-in from my staff yet. And so that's one of my jobs, to go through and say, I think that this is important and something that we need to do, and this is why it is important. I think that it also helps to get better integrated perhaps on, we don't understand this movement data yet. We've had it for 10 days. And so I'm playing with it, but beginning to look and saying, if we get these scores, do we have your support to say, you cannot do this? And I think that may be the most important thing, is saying, yes, their ACL looks great, yes, their motion looks great, and their strength is great, but they don't move well enough to return yet. Now, I don't know that that's appropriate. I don't know, as I said, I've had it for a week.
Which patients are you looking at to do this monitoring on? Is it going to be standard for everybody, or are you just going to look at selected people?
So for me, right now, I'd look at doing it for every re-eval, for every knee. Now, I don't know that our scopes necessarily need to do it, but I absolutely, in any ligamentous or any patients that have a protected weight-bearing status, I would look at doing it. And I would consider doing it at 6-week points if the patient was in Vail. If they're not in Vail, I would look at doing it for whenever they're in Vail for their follow-up times. And just making it part of our assessment. It's very, to do a double leg squats, 5 double leg squats. So it's not a big toll either in time or impact to do it. So that would be my thought today. Dr. Miller.
Nice presentation. Thanks for all you do to help our patients too. It really makes us better, and you guys do help us a lot, so thank you.
Thank you.
One of the things that I'm interested in is exposure risk, and that's kind of what you were talking about. I saw a patient last week. She's from the southeast. She moved here. She was a softball player. All of a sudden, in the southeastern U.S., she was the average player. Here, she moves here, and she's the star player. So she was pitched all the time, and her shoulder now has a problem.
Yeah.
I see that in some of the kids that are participating in ski club. They're skiing year round. They have more exposure. They're getting more injuries. How do we go about implementing or understanding what you're saying, these peaks and valleys, and knowing, all right, this is too steep of a progression. This is an acceptable amount of progression because, for example, the kids that go to these summer ski camps, they go from no skiing to full-on skiing because they haven't been skiing. So, how do we help them to understand what's safe and what isn't safe?
I guess if I knew the answer to that, we wouldn't have the problem, huh? I think, let me answer it in a roundabout way. If we were in Australia, which we're not, and you go into an elite sports setting, training is no longer dictated by the coach. Training is dictated by the sports science staff that have all this data that will say, today, this athlete is going to be allowed to run this much. Now the coach says, okay, with that amount of time, I get to do this, this, and this. But the total loads are determined by the sports science staff. If you come to the United States and you go in an elite sports setting, there is absolutely none of that. There's a little bit that's beginning to creep into the NBA, but it doesn't exist anywhere else. I think that it comes down to understanding or to educating the coaching staff that an injured athlete that is not performing to them is of no benefit. Also, however, an undertrained athlete isn't of benefit either. And so educating the staff that you need to have when you're designing your training programs for all the players, that it needs to look just what we said, a gradual increase in exposures or loading volumes. And then if you peak or valley them, then they're going to be at a higher risk of injury. And if they're injured, they cannot do anything for you in a team sport, and obviously not going to be able to do anything for themselves in an individual sport. Outside of educating the training staff, particularly in team settings, I don't know how to go about doing it.
I mean, is there scientific evidence about the peaks and valleys
Yeah.
philosophy? Because, I mean, all the collective bargaining agreements said they're not allowed to participate in practice outside college. They can't have organized practice. High school, they start 2-a-days. They can't do anything coordinated before that, so they go from kind of nothing to a high level.
Right, so I did a poor job and I missed here. I made reference in there that we had the Dallas Cowboys injury report up there. And I was going to point out that all bar 2 injuries, and I think there were 10 on there, were hamstrings or calves. And they are 100% preventable injuries, or I should say in another way, they are injuries that were caused by the training that they were doing, or inappropriate application of load or exposure. Because they went from nothing to where they were and bang, they got 6 hamstrings and 2 calves, which shouldn't, that's training load error. That is not my hamstring was too weak. And so not only I think is there evidence, but there's an increasing body of evidence over a whole number of sports and for a lot of different injury patterns. So it's in soft tissue, it's in stress fracture in bone, it's beginning to look at concussion with the Purdue group that's showing number of contacts and risk of concussion. So I do think that there is very sound and growing body of evidence to say, yes, we shouldn't be peak and valleying them because they're going to have an injury risk. Brilliant. All right, guys, thank you.